Right. Good evening, everyone. My name is Hassan. I'm one of the rheumatology leads from Mind the Bleep, and we've previously had a session on the different arthropathies and what to involve and how to look for them. And today we're going to be looking a little bit in more detail on vasculitis and what that involves, what vasculitis really is, and how to kind of really prepare for it for an exam standpoint. Now, it isn't a question that will come up fairly frequently, but it is a question enough times where a lot of students can get it quite wrong, can't really recognize it. And we want to talk about how to pick up some easy marks just from looking at the history, looking at the presenting complaint, looking through the blood work to get some understanding of what kind of vasculitis is present. So our objectives will be as follows. We are going to learn how to differentiate between small, medium, and large vasculitis. We're going to recognize the signs and the symptoms of the different vasculitides and how they present. And lastly, we're going to be talking about how to recognize the treatment pathway for the various arthrotides. From a UKMLA standpoint, the biggest point that you have to take away from today is going to be by far point number one and point number two. Point number three is important for your clinical practice, but it isn't as important for your examinations. So let's get into it. You've got different types of vasculitis. You have small, medium, large, and mixed. Those are the main categories that you'll need to know for all intents and purposes. And we'll talk about what each one is and what it represents, what's the difference between small vasculitis and a medium vasculitis and a large. The ones that you're going to see here are going to be Wegener's granulomatosis, Churg-Strauss granulomatosis, microscopic polyangiitis, Henoch-Schönheim purpura, and Goodpasture syndrome. Those collectively are the ones that are going to come up in small. Medium are going to be your polyarteritis nodosa and your Kawasaki disease. So there is going to be a little bit of pediatric involvement here, but I'll do what I can to avoid stepping on our pediatrician colleagues' toes. And lastly, and you also got large, which is temporal arteritis, GCA. To some extent, you can argue about PMR being kind of a precursor to that, and Takayasu's arteritis. And lastly, our mixed one is going to be Behçet's disease, ulcerations forming all over the body. So let's get into it. When we say vasculitis, what do we actually mean? Well, vasculitis means it's the inflammation of vascular structures, and that's pretty much any and all vascular structure. It can be a capillary, it can be a vein, a venule, artery, or it can be the massive aorta. When we're talking about small, we're talking about small intraparenchymal arteries, arterioles, capillaries, and venules. It's very kind of localized to that area. They're not going to be causing a systemic upset in and of itself with the inflammation that's caused at that vascular injury, but it will still present in a particular fashion. Medium is going to be visceral arteries and veins and the initial branches. We're talking bigger arteries that are supplying certain organs and are going to make sure that they are essentially their blood flow gets obstructed, and that leads to more of a systemic style presentation, and that can cause quite significant upset. Large, lastly, is going to be primarily aorta and major branches of the aorta, or a really large artery to begin with. We're going to be talking about like the temporal artery. We're going to be talking about the aorta. Essentially, if left unchecked really quickly, really rapidly, you can have a massive problem. So why is vasculitis a multi-system disease? Why is it not just, you have a bit of vascular inflammation, it affects that blood vessel, and you're done with it? Well, what happens is inflammation of vascular structures results in immune complexes being drawn in, which in turn causes the scarring. So you can see the scarring on this histological imaging here. You can see this fibrinoid necrosis, and that causes restricted blood flow to the organ. It's essentially starving the organ of the blood flow, both oxygenated and non-oxygenated, right? So you either have difficulty getting oxygenated blood, which leads to kind of ischemic damage, or leads to inability to function properly, inability to compensate for certain things, or venous blood being obstructed, meaning you're not able to dispose of waste products properly, you're not able to manage these things effectively, and over time that just leads to organ dysfunction. And these disruptions to blood flow because of the scarring can cause the direction of blood flow to change a little bit. If you have scarring, fibrinoid necrosis, particularly on one side, you can cause that to be weakened, that wall, and that can cause blood flow to prefer to pour into that wall, causing an aneurysmic picture. So this is not an exclusive list. As you can see from the diagram here, it is a systemic disease. It will affect every part of your body, but some of the ones that may make you think about vasculitis from an exam situation, and the most common ones that we see in terms of the conditions that we're going to cover are going to be your lungs and your kidneys. Additionally, you might see some messaging on the nerves and the joints, and the carotid aneurysm, as you'll see shortly, is a specific sign for certain vasculitides. Vasculitic rashes, I'll show you a picture of what that looks like. It's a very, very hemorrhagic, blister-filled, bruisey picture. It's not a very pleasant picture. It's very distinct, right? So some of the complications that we can have, if we're talking from a systemic viewpoint, you can have reduced visual acuity. You'll see that especially in an emergency situation like GCA. You can see a stroke. You can see peripheral neuropathy, mononeuritis multiplex. You can see polyneuritis as well. You can see very strong epistaxis, bloody stools, bloody cough, right? You might even see a bit of invisible hematuria, so you don't see that they're having urine being, bloody urine, but they're having, when you dip them, they got urine 3+, right? And your heart can be affected. Your heart can have a myocardial infarction because of these things. And it's important to note with the vasculitis, the reason why we're talking about it, not just from a UKMLA standpoint, but also from a clinician standpoint. People will never present and just say, oh, well, I've got vasculitis and this is how I'm feeling, and all these symptoms are related. They usually have a cluster of symptoms that may make someone think about initial presenting complaints first before you think about vasculitis. Vasculitis, usually people are coming multiple times and they're not getting better, right? So for example, someone can have joint pain and arthritis, and you can think, well, okay, maybe, Bob's a 70-year-old man. He's been working 50 years tiling roofs. Maybe he just has a bit of OA, give him a bit of topical NSAIDs and he's fine with that. But the reality is, you give him some NSAIDs, you give him some pain relief, you give him all these things, and his pain's not getting better. That should prompt you to think outside of the box, right? So you can have mimics of vasculitis, you can have malignancies. So a lot of the classic symptoms that you first see are going to be weight loss, fever, malaise, not feeling right, very non-specific symptoms, right? HIV and syphilis, infective style, can be a mimic of some of these presenting complaints, depending on what organ is affected and to what extent. Infective endocarditis can mimic vasculitis not only at a clinical level, but at a histopathological level. So it's very hard to differentiate the two, and you have to rule out infective endocarditis for a lot of them. Connective tissue disorders, so you got something like Ehlers-Danlos, for example, that can present in a particular way because your connective tissue is damaged, causing your organs to have a problem rather than your blood flow. It's difficult to actually identify on first presentation which one it is. It needs a workup to be done. And lastly, hypercoagulable states, of which malignancy can be one. So if someone comes in, they're having a nosebleed, they're having a bloody cough, they're having a bit of bloody stool, or they're having some, lightly bloody urine, that might be them having a hematological problem. That might be them having a platelet deficiency. That might be them having, some sort of hemophilia. That might be a lot of things. But it can be vasculitis, and therefore you have to exclude it as well. So when you hear about vasculitis, you'll hear us say ANCA, PANCA, CANCA, all these terms, and you go, what actually is that? What does that even mean? What does that represent? So for your exams, you'll need to know about two primary categories, which are your peripheral anti-neutrophil cytoplasmic antibodies and your central. So anti-neutrophil cytoplasmic antibodies, it's a bit of a tongue twister. ANCA, they're proteins that are made by the immune system that attack healthy tissue, specifically against neutrophils and the cytoplasm itself. So PR3 canker, so indicates immunofluorescent staining in the cytoplasmic region, and it's very sensitive to glomerulomatosis with polyangiitis, aka Wegener's granulomatosis. It's very sensitive for that. P-anchor indicates immunofluorescent staining around the nuclear region. There's a lot of P-anchor substances that you can be aware of, but the one that will probably come up in your exam, if they don't just say panca directly, is going to be myeloperoxidase, MPO. Microscopic polyangiitis, glomerulonephritis, Churg-Strauss, good pastures, they're all associated with panca and MPO. It is less likely, but possible, that you could have a canker-positive eosinophilic granulomatosis with polyangiitis, but from an exam standpoint, I would not expect that to be the answer. So we'll talk about the small vessel vasculitides. You've got two main types of small vessel vasculitis. You have anchor-associated ones, so you got your granulomatosis, eosinophilic granulomatosis, and microscopic polyangiitis. These are all anchor-associated in some way, shape, or form. So if you can see here, you can see panca immunofluorescent staining, right? And then you have immune complex small vessel vasculitis. So this is driven by some sort of immune process rather than an anchor-driven process. And that's going to be things like your IgA vasculitis or your anti-glomerular basement membrane disease, Goodpasture syndrome. Either one of those two is going to be immune complex. So when you see a question and you think that this is small vessel vasculitis, you should look to say, okay, well, is it going to be anchor driven or is it going to be immune complex driven? And if it's anchor driven, you have three options that it can be, really, for your exams: Wegener's, Churg-Strauss, and microscopic polyangiitis. If it's immune complex, well, you got your IgA vasculitis and your good pastures. So being able to identify which one this is going to be a good first step. So here you can see, a vasculitic-esque rash, and we're going to talk about Wegener's or granulomatosis with polyangiitis. So GPA is fairly rare. It affects about 2 to 14 people per million in Europe. It's got non-specific symptoms: fever, malaise, weight loss, arthralgia, which you'll hear me say for pretty much all of these conditions that we're about to talk about. But when it comes to your exams, what should make you think granulomatosis with polyangiitis is a triad of three types of conditions: upper respiratory tract symptoms, sinusitis, nasal discharge, hearing loss, epistaxis, right? All in the upper airway. And then lower respiratory tract symptoms: dyspnea, cough, hemoptysis, diffuse alveolar hemorrhage. So you're thinking your upper airway, your lower airway, they're both affected. Characteristically, in your exams, they'll probably mention some form of hemoptysis or epistaxis, or some symptoms that are quite out there, quite striking, right? And lastly, GPA classically also has kidney involvement. So GPA is kidney and lungs. Kidney, lung, and airway. That's the three to kind of take into consideration, right? So you can end up with microscopic hematuria, rapidly progressive glomerulonephritis, crescenteric glomerulonephritis, which you'll find from a biopsy. And these are the three things collectively, from a rheumatological standpoint, that you should look and go, okay, probably GPA, right? And let's look at the kind of the blood tests and go from there. You can, in reality, have other parts of the body affected. You can have your eyes be affected with scleritis. You can have petechiae on the skin, as you can see here. You can have neurological involvement, such as a mono or a polyneuropathy, right, depending on what extent it's involving. Risk factors, and you'll hear a lot of these risk factors be the same. There's not a lot of them for most risk factors. We have some immunological involvement, HLA-DB and HLA-B, which from an exam standpoint, I wouldn't think too much about. Just know that there's some sort of immunological involvement. Tobacco usage is linked to GPA. Some pre-existing infections can be shown to have long-term damage. So not a current infection, but a long-standing infection that was treated a while ago. It's more prevalent in older years. You're not expecting to see GPA in someone who's 30 years old, and it is slightly more common in males and men. So how do we diagnose it? Well, you do a workup. With all of these, you're going to do a workup, and if I understand correctly from your exams, it's going to be one of two things that are going to be asked. What is the workup, and what is going to be the diagnosis, right? So they're either going to suggest some things that might be GPA related, and you think, okay, let's work up to this. What should I do next? Or what should they've given me all this workup, they've done the biopsy, they've done the imaging, they've done the blood tests. What do I think this is? So clinical features we've talked about. The history is going to be really important. General symptoms, upper, lower respiratory tract, and kidney involvement. Classically, you'll see hematuria, hemoptysis, and some sort of unexplained cough or some sort of congestion. It is canker positive up to 90% of cases. 90% of cases which are GPA confirmed are canker positive. You can have P anchor. You can be P anchor positive for your exams. Don't assume just because it's P anchor positive that it can't be GPA. Think about what's most likely to be the case. We expect to see someone be C anchor positive rather than P anchor positive, but if they're both, we look more at the history and the examination. Imaging, so you do a chest x-ray, you look for any diffuse alveolar hemorrhages, as you can see here, and you do a high-res CT. You're looking to see how the lungs have been affected. You're looking to see if there's any features of vasculitic changes, right? And from a histopathology standpoint, you're going to do a biopsy. You're either going to do a biopsy of the lung or of the kidney, and this is where you need to put your doctor hats on and kind of think which one is going to be more practical. So in someone who's got, I don't know, end stage renal failure and they've kind of presented like this and it's a very strange situation, you might think twice about doing a kidney biopsy. But in someone who has, in that same person, let's say their lungs are healthy, it might be lower risk to take something from the lung. Treatment-wise, is going to be a couple of things. If this is life or organ threatening, this is going to be an admission. This is going to be IV methylprednisolone 3 to 5 days, followed by a mixture of cyclophosphamide and oral pred. If there's signs of kidney failure or organ dysfunction, so kidney failure, lung failure, you can use plasmapheresis. And second line, for life organ threatening GPA treatment, this is all for inducing remission, is IV methylpred and rituximab IV. And if it's non-life threatening, if they've come into AMU and they've said, okay, well, I'm feeling this way, and you've got a rheumatologist on hand who says, let's treat them for GPA, then you can give them some methylpred for 3 to 5 days, and instead of giving cyclophosphamide, you give PO pred with methotrexate. And then you can give either a combination of oral pred and cyclophosphamide, oral pred and rituximab. These are all options that you have, and depends on what suits the patient best. This is all for remission induction. For vasculitis, your treatment is going to be 2 steps in virtually all of them, which is inducing remission and maintaining remission. So maintenance is going to be a mixture of pred and methotrexate, pred and azathioprine. Make sure you cover for prophylaxis. So you got your gastric ulcers that can form because of steroid use. You got your osteoporosis that can form because of steroid use. You're immunosuppressing them, so they need to be PCP aware. If they need prophylaxis for that, that might be worth thinking about. You can gradually, over time, reduce the dose of steroid. You can bring that down as and when they tolerate. Depending on the patient, depending on how severe the condition is, sometimes you bring that dose of pred down, they start having these symptoms again, and it's quite difficult to wean sometimes. But that is our mainstay treatment, is going to be suppressing the inflammation to whatever degree we can. Now we'll talk about Churg-Strauss or eosinophilic granulomatosis with polyangiitis, eGPA. It's even rarer than GPA. Again, it has the same symptoms, it's broadly the same symptoms, I should say, which are fever, malaise, weight loss, and arthralgia. What's very different compared to GPA, the thing that will tell you apart in an exam, is look for new onset allergic symptoms. So the first stage of eGPA is allergic symptoms. allergic rhinitis, new onset asthma as an adult, having these sorts of presentations will make someone more likely at an initial workup to be eGPA. All right. We don't expect someone with GPA to be new asthmatic, new allergic rhinitic. We expect them to just have these things, or we expect them to have symptoms that are just not going away, really. For eGPA, there is that allergic stage. Then you get an eosinophilic stage, you get your weight loss, night sweats, abdominal pain, GI bleeding, fever, malaise. And then from there, you get the vasculitic stage, which affects pretty much all the organs in your body. Because as you can see from the diagram here, the inflammation essentially causes the lumen to, instead of be nice and smooth and allow for good flow, to be very craggly and allow for turbulent blood flow, which in then affects the organs. eGPA, not from an exam standpoint, but eGPA can also affect the heart, can cause left ventricular dysfunction, pericardial effusion, heart failure, tamponade. And it's worth noting with all of these conditions, particularly eGPA and GPA, if you leave someone without treatment, if you think they have it and you don't treat it, the life expectancy is very poor. Remission induction is very, very important. For GPA, I think off the top of my head, it's about 6 months. 6 months that someone will have, a very poor quality of life if their symptoms aren't left in check. So again, HLA appears to have some sort of a relation to eGPA. We don't really know to what extent, right? Allergens. So I think if someone has a history of allergic reactions, they have an allergic reaction to food, or they have an allergic reaction to medication, certain materials, that might put them more at risk of developing eosinophilic granulomatosis with polyangiitis. If they've had certain drugs like montelukast, if they have certain atypical responses. For example, I've seen a woman who had an allergic reaction to an antibiotic, and instead of kind of having the classic anaphylactic type presentations, she just went almost very absent, like almost absent seizure like, which was a very atypical response. It got better with adrenaline, of course. Bacterial and viral infections that kind of dysregulate your immune system, historic ones, and these are all pretty much inconclusive. In reality, we don't really know what is causing eGPA. We don't know what the underlying mechanism for it is. Again, clinical features. So the main things are going to be those B symptom-like presentations, weight loss, potentially night sweats, can have fever, can also have the arthralgia and the joint pains, not feeling themselves, tired all the time. And then on top of that, from an exam standpoint, think asthma. Think asthma, think rhinitis, allergic rhinitis. You should not be developing these things beyond the age of, say, 25, 30, maybe at a push 35. If someone's coming in, they're 50 years old and they're now a new asthmatic, they never smoked a day in their lives, that's a bit strange. That's not what we expect to see. And that can be your sign to tell you, okay, let's do a eGPA workup. Bedside investigations. So again, you're going to look for routine. You're going to do routine bloods, your FBC, your USNEs, your LFT, your CRP. Now, note in eGPA, if we go back a little bit, when we talk about symptoms, it can affect your kidneys and can affect your lungs, but it's less likely to. We generally see this kind of new persistent asthma, this allergic rhinitis, this fever and the malaise and the weight loss, right? You might see some GI bleeding, but not as much affecting your lungs and your kidneys specifically. From an exam standpoint, you'll see that in your questions. Someone will say, you got hemoptysis and hematuria. They don't got cancer. It's not been shown to have a cancer. What you're thinking this is. And that's more GPA-like. eGPA, think asthma, right? You can see leukocytosis, thrombocytosis. If they have a particularly raised IgE level or they have particularly high eosinophils, that might indicate to you that this is more in like allergic cell driven, which in turn might tell you that this is more eGPA driven. It's much more likely to be P-ANCA positive and therefore anti-MPO positive. CANCA usually isn't positive for eGPA. It can, but it usually isn't. For your exams, if someone is CANCA positive, you shouldn't think eGPA as your first line. Again, chest X-ray and high-res CT. You're looking to see if there's any kind of vasculitic changes in the lungs, and really you probably want a biopsy to see if there is any effective problems in the lungs. And as you can see here, this is all immunofluorescent staining. You can see it's affecting the periphery of the cells, and that can tell you exactly what's going on. So this is more of a PANCA presentation. Primarily think about PANCA and anti-MPO from an exam standpoint. Treatment is going to be pretty much identical, which makes it a bit harder to tell even. Remission induction is virtually identical, and it's not something that I would try and rote remember. I would just broadly remember the type of treatment induction, what kind of treatment we use. We're talking cyclophosphamide, we're talking rituximab, we're talking your steroids, of course. Maintenance, methotrexate is going to be one, and the other one that I think as of right now is licensed. I think it was licensed about a year ago now. Mepolizumab. It is an IL-5 monoclonal antibody. It reduces eosinophil production. Now, I don't expect this to come up in your exam, but just for anyone who wants to be curious about these things, it reduces eosinophil production, so therefore it reduces eGPA. And we have upcoming drugs which are not yet approved. Now, microscopic polyangiitis, it is a necrotizing vasculitis in small vessels. Again, you can see fever, malaise, weight loss, arthralgia, and you can cause musculoskeletal, neurological, dermatological, cardiac. Pretty much anything can be affected by microscopic polyangiitis. Main risk factors that we have associated with it is silica usage. So if you're exposed to silica, so if there's an occupational risk there, that might be quite a risk factor for MPA. If you're in the south or if you're in the winter seasons, you're more likely to develop MPA, the mechanism of which is not really understood. If you've had a historic infection with hepatitis C or Staph aureus, you're more likely to develop it. Hydralazine, thionamides, sulfalazine, minocycline, they're all associated with MPA. It's a risk factor that you can cause it to develop, and of course a family history. So diagnosis components, again, it's going to be the same workup that we've done. So your bloods, your ANA and ENA, just to rule out any other conditions. PANCA positive, it's MPO positive, it's CANCA negative, and you might do a chest X-ray, high-res CT, or a biopsy from the affected organ. When we talk about symptoms here, it's probably worth noting you get all these generic style symptoms. So you get the joint pain, the arthralgia, the mononeuritis multiplex, the rashes, tummy upsets, abdomen bleeding. It's very generic. So the way how I would differentiate from MPA, from GPA and eGPA is between GPA and MPA, I think, okay, is it primarily a respiratory and renal problem, or is it a generic problem? And that's the first line that I would tell. And the second line that I would tell is I would tell with using eGPA as an example, if there's a new onset asthma or anything of that nature. So going back to the treatment forms, for severe MPA, organ-threatening MPA, you're thinking cyclophosphamide, you're thinking your steroids, you're thinking plasma exchange, if there's any evidence of renal failure. If it's non-severe, you're going to be treating them with prednisolone and methotrexate or mycophenolate to induce remission, and maintenance is going to be prednisolone or azathioprine or methotrexate, depending on what is indicated or contraindicated. Now, we get into our immune complex-driven vasculitides. So we've got your Henoch-Schönheim purpura. This is primarily going to be affecting children, and in your exams, I'd be very remiss if it was someone above the age of 15. It's a type 3 hypersensitivity. The IgA complexes, they deposit in vascular walls and they trigger complement activation, and that then leads to this vasculitic picture. Now, there's four main symptoms. You have palpable purpura. So you can see here this hemorrhagic, blistery rash, very unpleasant, very distinct. Arthralgia, glomerulonephritis, and abdominal pain. So your kidneys are going to be affected. They're going to have tummy pain, and they're going to have this rash. That's the classic triad, but they might also talk about arthralgia from an exam standpoint. About 50% of patients who have HSP or IgA vasculitis have had a strep infection in about 1 to 3 weeks beforehand. So it might be like a delayed reaction that they're having. It can also be involved with GI infections, and that can be a trigger, but it is primarily infection driven. Strep A, 2 to 3 weeks later, they come in and they've got this rash, and then they've got tummy pain, and they're having problems with their wee. It's primarily a clinical based diagnosis. You don't really need to do a renal biopsy for IgA vasculitis. It's quite cruel for a 10-year-old to have a renal biopsy unless it really need it. You can do bedside investigations, routine bloods and urine dip. Serum IgA, you expect it to be raised, but it's only raised in 1/3 of patients. And it's worth, from an exam standpoint, when you think about IgA, you should also think about ITP and TTP, your immune thrombocytic purpura and your thrombocytic purpuras, and the coagulation screen will rule that out. If your diagnosis is not sure, if you're really thinking, this isn't fitting with vasculitis, this isn't a classic IgA, you could do a biopsy of the skin, of the kidney, of the GI tract, essentially looking for those IgA deposits, which are, as you can see here from the arrow. If there's abdominal involvement and it's very severe, and you're wondering to what extent you can do a CTAP, but again, remember, these are kids that you're dealing with. Giving them a lot of radiation is not really in their best interests, unless it will guide management significantly. But it is primarily going to be clinical. It is based on purpura, abdopain, glomerulonephritis, and usually with this history. From an exam standpoint, I would be very surprised if something different came up. Treatment-wise, if the kidneys aren't involved, analgesia, you give them a bit of supportive management, make sure that they're taken care of. If they are in extreme gastrointestinal stomach pain, GI pain, sorry, you can consider steroids. Steroids generally in quite young people is a bit of a suspicious step. We don't want to put people on steroids unless we can avoid it. If kidneys are involved, so if you're having hematuria, if you're having signs of nephritic symptoms, and they're very rapidly having rapidly progressive nephritis, you give them some immunosuppression, you do plasmapheresis. If it's more of a nephrotic style picture, so they're losing all their albumin, they become very swollen, and they've got kind of +4 proteins on their dip, we pulse some steroids in them. And it's worth noting, about, I think, 5 to 10% of IgA vasculitis patients, you can have end-stage renal failure because of it, which means that they need a kidney transplant. Lastly, I think from the small vessel vasculitis, this is another immune complex-driven one. It's Goodpasture syndrome. It's an attack on type 4 collagen, which is found in the basement membrane of your lungs and in your kidneys. And your symptoms are going to include a hemoptysis, maybe a cough with that. It can turn into a diffuse alveolar hemorrhage. You can have shortness of breath, decreased urine output, hematuria, which can then develop into rapidly progressive glomerulonephritis or crescenteric glomerulonephritis, fatigue, and malaise. Now, it's worth noting, these are very, very, very similar to your GPA symptoms. Right? So we'll talk about how to differentiate those in a moment. Your main risk factors are going to be, you work in, say, the crude oil industry, you work exposed to hydrocarbons or tobacco smoke, or you've had a history of long-standing viral respiratory infections. Some genotypes are more likely, more prone than others, but if asked about risk factors, I'd probably focus on this section here. Diagnosis components. So again, we're going to I've made a slight error on that slide here. Shouldn't be talking about IgA here, but you're going to do the same features. It's going to be primarily clinical driven. You're going to do an anti-GBM blood test. That is going to be a very good tool that you can use to identify. So anti-GBM, anti-glomerular basement membrane, tells you essentially your type 4 collagen is being attacked, which is why your lungs and your kidney are being affected. The definitive diagnosis is a renal biopsy, because that allows us to see if there's crescenteric glomerulonephritis or if there's IgG staining on immunofluorescence. You can do a CT scan in general if you're thinking about high-risk CT for diffuse alveolar hemorrhage, or if you're thinking about any kind of renal problem, you could do a CT scan from that aspect. But you're going to rely on your anti-GBM to drive things. From an exam standpoint, what I would say is, if you see something that looks like GPA, but there is anti-GBM membranes, anti-GBM. If you find the anti-GBM substance in the blood, that is much more likely to be Goodpasture syndrome. We don't really have any guidelines for managing Goodpasture syndrome. We manage it with immunosuppression and plasmapheresis, or all plasmapheresis, but we don't really have any strict guidelines on Goodpasture syndrome treatment. So that's all the small vessel vasculitides. We're talking now about the medium vessel vasculitides. And we want to talk about polyarteritis nodosa. It's necrotizing inflammation of medium-sized elastic and muscular arteries. It typically affects most organs, typically spares the lungs. So here we have a look at some of these symptoms. We've got these general symptoms that we've talked about here. You can have a mononeuritis, you can have sensorimotor neuropathy, you can have livido reticularis, which we saw on the slide here, this kind of purple, fishnetty, weird rash. You can, in your liver, it's not going to be hematuria. That's an error on my part. I apologize. It is going to be liver dysfunction. So your ALT, ALP, AST, potentially even GGT can all be affected. Your liver is affected. You can have hematuria from your kidneys, and you can see here microaneurysms on your kidneys. From a cardiovascular standpoint, you have cardiomyopathy and pericarditis, and from a vascular standpoint, you can of course develop a stroke, peripheral vascular disease, and aneurysms. As you can see here from there, these are renal and microaneurysms. And it's worth noting, I'm just going to reiterate again, you can have two of these, or any one of these symptoms come on its own. For example, you can have someone come in, let's say they're a 60-year-old man, they come in with a pericarditis, or a 75-year-old man, they come in with a stroke, or someone who comes in with isolated hematuria. They don't have to have all of these symptoms, and that's what can make vasculitis so difficult to diagnose. By far, the biggest link to polyarteritis nodosa is going to be hepatitis B exposure or disease. So having hepatitis B is associated with about 30% of cases. Hep C, HIV are also known to be linked. Hydralazine, cocaine, propylthiouracil, allopurinol are believed to be associated with polyarteritis nodosa, but the evidence is a little bit weak for some of them. Diagnostic components, you've got your clinical features, again, that we've talked about, your bedside investigations, so your blood work, your LFTs, your U's and E's. You want to do a dip here. You want to do a viral serology here. You want to see what's their Hep B status like. Are they vaccinated? Have they had a previous exposure? So if they're having any kind of renal infarctions, or you're suspecting that they've got quite severe renal disease, you can do a CT-AP or an MRI, which can show these infarctions. And then you can do arteriography to kind of look at the aneurysms, to see, well, okay, if they're having multiple aneurysms in multiple parts of the body, that can be fairly diagnostic of polyarteritis nodosa. And again, you can take a biopsy from the affected organ. If it's primarily a liver-driven problem at the moment, you can take it from the liver. If it's a kidney derivative problem, you can take it from the kidney, etc. Treatment, you're going to do pred at about 1 milligram per kilogram per day. If it's an organ-threatening disease, you're going to give them cyclophosphamide. Maintenance is going to be azathioprine or methotrexate. And then on top of that, you're going to do symptomatic treatment. If they have neuropathy, you're going to give them gabapentin. If they're having renal damage, which is causing high blood pressure, you're going to give them antihypertensives, and so on and so forth. Kawasaki disease is our classic PEDS-only condition. I know we've talked about IgA vasculitis, but with Kawasaki disease, it should really just be with kids. It's not well understood. We don't know why it happens. We don't know what's really affected, but the symptoms are quite distinct. If they have a high-grade fever which has lasted for more than 5 days, think Kawasaki disease. That should be in the back of your minds. From an exam standpoint, if you see a child who has a fever for more than 5 days, you should start thinking about Kawasaki disease. They can have a strawberry tongue, red cracked lips, cervical lymphadenopathy, kind of red palms on the hands and the soles, which kind of peel away. And it is a clinical diagnosis. You don't need to biopsy them. You don't need to image them. You don't need to, you can do a blood workup to rule out other things like just a generic infection, but it is a clinical diagnosis. Treatment for it is going to be high dose aspirin and intravenous immunoglobulin. Now, that's all you need to know. High dose aspirin, intravenous immunoglobulin. And the big complication with Kawasaki disease, the reason why we're quite worried is because it can cause a coronary artery aneurysm, which left unchecked can cause a massive bursting of said aneurysm with fairly high mortality, right? And the way how we prevent that is serial echoes to see how the blood vessels are. If there are any aneurysms, they need to be regularly monitored. And if they are a particular size, they might need pediatric vascular involvement for a surgical repair. Now we'll talk about large vessel vasculitis. We got Takayasu's arteritis. It's a large vessel vasculitis that affects the aorta and branches. It almost exclusively happens in female. About 80 to 90% of incidence is in women. It's associated with HLA-B52, but I wouldn't worry about that too much for your exams. Again, you got your general symptoms, fever, malaise, and weight loss. Interestingly enough, or more specifically, you can have pulselessness in at least one or more peripheral limb, which could be just the right radial or the left popliteal or whatever pulse you're struggling to find for whatever reason. You can have limb claudication. Now that overwhelmingly is much more likely to be in one of the upper limbs. It's quite unlikely to be for lower, just from clinical presentations. You can have bruits when you listen to them. You can have an aortic regurgitation when you listen to them. You can have kind of resistant secondary hypertension. You can have ocular ischemia, and you can have a vascular event like a stroke or a TIA. Now, from an exam standpoint, I'd expect the pulselessness, the limb claudication, potentially the bruit, maybe the secondary hypertension. I wouldn't expect these last two. Diagnostically, you're going to do all your blood work that you've been doing. You're going to look for these clinical features, and you're mainly going to be focusing on imaging. You're going to be looking at the chest X-ray for any widening or mediastinal involvement or pulmonary involvement. You're going to do a CT angiogram. You're going to do an MR angiogram, whichever one you can get your hands on first, because you need to look at what your blood vessels are doing, right? It is a dangerous condition. If they're having an aneurysm, it can burst very quickly. We need to know. You can do a Doppler for peripheral vessels if you're thinking, okay, you know what? It doesn't seem to really align. We can do a Doppler to see if the peripheral vessels are affected, but for something like Takayasu's, I would go with a CT scan before anything, really. And you can do arteriography to kind of look through and see if there's any aneurysms. Main treatment is going to be prednisolone, and it's going to be aspirin. We give the prednisolone to suppress the inflammation. We give the aspirin to reduce the risk of a clot forming. And you can try other immunosuppressants if they relapse while on prednisolone, but that's going to be up to the discretion of the rheumatologist looking up to the patient, seeing which one's most appropriate. GCA is a last vessel vasculitis that affects temporal artery. It almost exclusively happens in someone 60 or older. They have a rapid onset, comes on less than a month. Headache, jaw claudication, palpable temporal artery. They start developing visual symptoms, blurring, diplopia, amaurosis fugax. So GCA and temporal arteritis are going to be used interchangeably here. Risk factors are primarily age and gender driven. Women tend to be affected more, and polymyalgia rheumatica. So if they have a history of polymyalgia rheumatica, they are quite likely to develop giant cell arteritis. So if they have that girdle pain, they have stiffness in the morning, it's worse in the morning with the pain, it gets better with exercise, think PMR, think GCA. Now, diagnostically, according to the American Society of Rheumatology, if any of three of these things are present, it should be highly suspicious for GCA. So if they have a new onset headache, if they have ESR above 50, which is a bit more sensitive for GCA than CRP, if they have an abnormal biopsy, if they have an abnormality on a temporal artery ultrasound, and if they're older than 50 years old. Any three of these should make you highly suspicious of GCA. So you've got two main diagnostic tools. You have your temporal artery biopsy and your ultrasound. So if you go back here, you can see around here, this is your right temporal artery. You got this here is your actual blood flow. You can see the Doppler going through. The rest of this is so inflamed that blood isn't allowed through properly. So temporal artery biopsy can show signs of inflammation, but can also be normal. You can have skip lesions. So it's usually recommended that you do about 2 of them at the very least. And you can have a temporal artery ultrasound. So you can do halo signs. You can see thickened vessels, as you saw earlier. You can see some stenosis. Not all patients are suitable for temporal artery biopsy. It is a fairly invasive procedure. If there's a high clinical probability, you can do an ultrasound alone, and if that shows positive signs, that might be sufficient for a diagnosis. Treatment is going to be high-dose oral pred if they have no sight-threatening symptoms. If they are having sight-threatening symptoms, really ophthalmology should be involved as well, and they're going to give them IV methylpred. You can consider methotrexate, tocilizumab in patients who can't use long-term steroids. So if they're at risk of becoming diabetic or it's affecting their blood sugar control, you can consider these alternative immunosuppressants. So the last thing that we'll be talking about, which have a couple of questions on the page, and then that'll be the end of the session. So 47-year-old man sees his GP complaining of a 4-month history of fever, jaundice, and nausea and vomiting, myalgia and weakness, weight loss, and flank pains with a sensation of itchiness. He describes at least 2 episodes of hematuria. He denies a cough. He denies hemoptysis. He denies any respiratory symptoms. You can see small palpable purpura on the lower legs and arms. He tells you that he was recently diagnosed with hepatitis B. His main blood work is, as you can see here, the renal ones had not been reported yet. He's got an ALT of 260, an AST of 230, ALP of 80, and GGT of 50. Which one of the following is he most likely to develop? Is this most likely going to be an eosinophilic granulomatosis with polyangiitis, granulomatosis with polyangiitis, polyarteritis nodosa, giant cell arteritis, or macroscopic polyangiitis? So for this question, the answer is as follows. It's most likely going to be polyarteritis nodosa. And it's quite simple if we break it down a little bit. We can see a fever, which is a non-specific symptom. We can see jaundice. Jaundice should make you think liver being affected, which from an MLA standpoint should make you think about polyarteritis nodosa already, but if not, that's fine. We have our jaundice, which is affecting our liver, nausea and vomiting. So we've got some GI involvement. Myalgia and weakness might just be generic symptoms, as is weight loss. Flank pains and a sensation of itchiness. So the sensation of itchiness is likely driven by a raised bilirubin because he is jaundiced. He describes 2 episodes of hematuria, so that means he's got renal involvement. He denies a cough, hemoptysis, or any other respiratory symptoms. So eGPA and GPA can be ruled out already, right? Because they are more likely than not going to have respiratory involvement. You see small purple purpura, which again is not specific, and it tells you that he was recently diagnosed with hepatitis B. So GCA is very specific for having kind of your polymyalgia rheumatica symptoms and your visual symptoms, neither of which are present here. And microscopic polyangiitis, it could in theory be, but we know that an association of hepatitis B is much more associated with polyarteritis nodosa. So, which rheumatological condition is he most likely to be developing? It's probably polyarteritis nodosa. It's not going to be these two because there's not really any lung involvement. It's not this because, well, he's not got any visual involvement. And it's not this because this isn't associated with hepatitis B. So, a 70-year-old man presents to ED with a 2-hour history of sudden onset blurring, diplopia, as well as aches and pains in his hips and shoulders. Temporal ultrasound show the halo sign and arterial thickening. What's the most likely diagnosis? I've unintentionally revealed that already, but it's going to be your GCA. And the reason why we can be quite quick with this question, we're talking about very specific symptoms here. We're talking about your hips and shoulders. We're talking about blurring of vision that came on suddenly. It's not going to be eGPA, GPA, or PAN because they don't present this acutely and they're not specific to your eyes and your joints. Kawasaki disease, well, there's no sign of a fever. Temporal ultrasound, the halo sign and arterial thickening are classic GCA signs. Now, our last question is a 55-year-old man presents with recurrent sinusitis, nasal discharge, and hearing loss. He also reports dyspnea, cough, hemoptysis, and hematuria. He's got a raised ESR, a raised CRP. PANCA and MPO were negative. He was CANCA positive. What's he most likely to have? Well, I'll hold for a second before I reveal the answer. He probably has GPA, right? We've got recurrent sinusitis, which is your upper airway, hearing loss. Could be upper airway related, could be hearing related, but all of these are upper airway symptoms. Dyspnea, cough, hemoptysis, lower airway, and hematuria. We got a classic triad: upper, lower, and renal involvement. He's PANCA negative, he's MPO negative, eGPA is going to be out of the picture. Kawasaki disease is not going to be in the picture because he doesn't have a fever. GCA is not involved because GCA doesn't cause hematuria or hemoptysis or any of these other symptoms. And polyarteritis nodosa, well, we know that the lungs are affected. PAN usually spares the lungs, so we know that it's not going to be, it's going to be GPA. And I think that is the end of my session. I hope that you found that useful, and best of luck with your exams. From a summary perspective, we've talked about small, medium, and large vasculitis. We've not primarily talked about the mixed vasculitis such as Behçet's disease, but what you need to know for that is it's going to be vasculitis that has involvement in all three of these vascular structures. It's going to be a widespread formation of ulcer. HLA-B51 is most likely associated with it, and it can be, as you can tell from the name, Behçet's is a very Turkish name. It typically affects people of Middle Eastern origin or Mediterranean origin more than anyone else. But we talked about different vasculitides, how to tell them apart, and now if you see these questions, you know what to look for in terms of the blood work and in terms of the imaging, and I hope